Welcome to the second WBUR CitySpace virtual town hall, and thank you for joining us and for joining each other in the midst of this pouring rain. And a special thanks to our formidable guest, Dr. Kevin Tabb, President and CEO of Beth Israel Lahey Health. I'm Carrie Goldberg. I cover health and medicine and science at WBUR, and I edit the Common Health section on WBUR.org, where you'll find most of our COVID-19 coverage online these days. As I said last week, I think I speak for the entire staff of WBUR when I say, we hope we're helping you. This is a very harrowing time for just about everybody, and we're all doing our best to bring you reliable information, even when so much remains unknown or unpredictable, and maybe to even make the time in captivity at home a little more tolerable with some familiar, calm voices and a never-ending stream of stories. A lot changes in a week, at least in times like this. And we are now unquestionably in the surge, the peak of COVID-19 cases, and with them, the losses, loss of lives, loss of jobs, loss of in-person connections. And I think the only good thing that can be said about the surge is that surges, by definition, end. And so even though we have quite a ways to go yet, it seems reasonable to start looking ahead to what to expect when this one does end, especially because we're starting to get indications that we've hit the plateau, it's looking like, and we may soon be heading downward now. So Dr. Kevin Tabb is here with us to talk about what's happening now and what could come next. And I'm sorry, I know the war metaphors are getting very overused, but I think it's fair to say that he's kind of like a brigadier general in the war against the virus. He leads Beth Israel Lahey Health, a relatively new entity here in the Boston healthcare world. Its creation was finalized just last year, and it brought together 13 hospitals, including Beth Israel Deaconess Medical Center, the Lahey Hospital and Medical Center, and Mount Auburn Hospital, and many others. So overall, he oversees more than 35,000 employees, and they're in the thick of the COVID fight. All told, they've been treating about 20%, I believe, of the state's COVID-19 patients. They have close to 190 COVID patients in intensive care now, out of about 740 hospitalized COVID patients overall. And the Beth Israel Lahey Health System is looking like it's at or near what's expected to be a long plateau, with the number of COVID inpatients rising over the last 7 days by just about 1% a day. So it's looking relatively flat, though still rising a little bit. And Dr. Tabb, through you, I'd like to thank your staffers for their service and thank you for your service. If we keep using that brigadier general metaphor, you're not in the actual trenches, but you're kind of back in the command tent, and every decision or plan that you make has human lives riding on it, or could. So I'd like to start on a very personal note. What is this like for you, and what keeps you up at night, and what keeps you going?
Well, first of all, Carrie, thank you for having me this evening, and happy to be here and talk with you and all of the listeners. I think I want to start by saying that really the thanks goes to the frontline caregivers. They are doing amazing work every day, every hour, and I hear from them constantly. Their spirits have not flagged in any way, shape, or form. But people are very tired at this point. This has been going on for a long time. And I think we expect that it will continue for some time into the future. And so, one of the things that keeps me up at night is, how do we make sure that we can continue with all of the energy that we put into this for some time, into the foreseeable future. But, when I think about what keeps me up at night, I guess the truth is that those things change over time. What was true 2 or 3 or 4 weeks ago, the things that might have kept me up even 2 or 3 weeks ago, I'm more comforted about now. And then there are other things that I'm worried about now. So 2 or 3 weeks ago, I think many of us were very, very concerned that we would hit the peak of the surge and be overwhelmed. And that has a very specific meaning. We were concerned based on what we had seen in other countries and even what we'd seen in this country, in New York, that our hospitals would be overwhelmed, that we would not have enough beds, enough ICU beds, enough staff, enough ventilators. And in reality, we have been able to provide care, and I would contend superb care to everybody that's come to us. Now, I would not tell you that that's been easy. The reason we've been able to do that is that we have what we call flexed up. So if you look, for instance, at our ICUs, we're very, very full at the moment. As a matter of fact, we are running at somewhere between 115 and 130% of our original capacity. And what that means is if we had not changed what we do and where we care for patients, we would have been overwhelmed. But we had a little bit of time and a lot of work. And we turned other floors and other beds and other spaces into ICU spaces, and we've been able to take care of everybody that we need to. So I'm not so worried about that anymore. But I think the things that I wonder about are how do we maintain the sort of things that we've been doing for longer, and what does the next phase look like? And so the things that keep me up at night are probably the same things that keep all of your listeners up at night. How long is this going to last? What is the next wave? Is there a next wave? And what does it look like? Those are things that we're looking at very closely.
And is there some reason why you wouldn't be able to maintain what you're doing now?
No, we will find ways to do whatever it takes. But this is exhausting for our frontline caregivers. And I think we need to acknowledge that too. This is, it's a crisis that is different than anything else that we've dealt with. I was here and ran Beth Israel Deaconess Medical Center during the Boston Marathon bombings. And those were horrendous times, but this is different. This is larger in scale, and that was time limited. I think the things that make this so different for us are the fact that it's got a bunch of different pieces to it that we're not used to. So there's a medical issue, meaning we're dealing with a disease that we don't know a lot about and don't quite know how to treat. So that's one part of it, although that's not unique in and of itself. That's been true of other things. We're dealing with a capacity issue. So I described the fact that we could potentially be overwhelmed and are very, very full. That's the second. The third is, honestly, for all of us, including for the caregivers, this is also a personal issue. In addition to dealing with the patients, people are worried about themselves and their loved ones. Are they going to get sick? And that is not typical for what we do. And then lastly, I'd say there's a financial component of this also. There's unprecedented economic devastation all around us, and it hasn't spared the hospitals. So when you add all of that together, it makes this very challenging. It also, though, gives me even more pride to know that given all of those things, we've really risen to the occasion.
So is that the thing that keeps you going then, that feeling?
It does. That keeps me going. The outpouring of support that we hear from the public for our caregivers, some of the stories that I hear from our own people. I got an email about a week ago from an MRI tech in one of our hospitals, and she wrote me that she was working with a colleague, and they were doing a scan on a COVID positive patient. And she told me that she was a single mom with 2 kids at home. And her colleague stepped in and told her, you know what, I've got this, I'll do it. You have more to lose than I do. And, I hear stories like that all the time. And so that is really the kind of thing that keeps me going, knowing the kind of people that we have.
People stepping up.
Yeah, absolutely.
Beautiful. Okay, so let's move to what's going on right now. But first, just a word to viewers. If you haven't already sent in a question, you're welcome to do so anytime during this hour. Just go to slido.com. We'll do our best to get to it, although we've gotten a lot of questions, so we may not, but we will try. Okay, Kevin, current moment. Are we in Boston and Massachusetts at the peak of cases and hospitalizations? Are we at the plateau, at the top of the bell curve? How will we even know if we are? And then a couple of side questions that you can lump all together. A lot of people are wondering why we have it quite so bad here. Do we know? What's your sense? And why, if we've all been, locked away for so long, why are there still so many cases? So present moment, explain it.
So, I guess I'll answer that question the way that I'm going to have to answer many questions, which is we don't know exactly.
Mm-hmm.
We have thoughts about where we are going to be, but the truth is that we will only know that we're at the peak when we've passed the peak. And I don't think that that's actually happened. That being said, we do see a number of things that encourage us and would give us reason to believe that we are getting close to that point at which we won't see further significant rises. So we follow this on a daily basis. The surge simply means that cases are increasing day over day. And we've been in the surge, in other words, cases increasing day over day for some time now.
Yeah.
The peak means that we will no longer see more cases tomorrow than we saw today. And we don't know, we're not quite there yet. But what we do see that gives us hope is that the percent increase in the number of patients we see on a daily basis has been mitigated a little bit. So whereas a few weeks ago, even 7 or 8 days ago, we were seeing day over day rises in the high single digits or double digits in terms of percentages. Mm-hmm. And now, when you look out over a 7-day period, we're seeing there are some days that are much worse than others, but we're seeing on average for the last week about a 1 to 2% increase. And when I say we, by the way, I mean Beth Israel Lahey Health, but I really mean all of the hospitals throughout the state. We talk to each other daily, in fact, multiple times a day. And I think the things I'm describing are similar to what's being seen around the state. And there are days when it feels like it's much worse today than it was yesterday. But it's important to look at the trends. And the trends would suggest that the rise is slowing. Now, how long? So I think we're probably at or close to what we would call the plateau. That doesn't mean that we're not full. We're very full. The plateau means actually we're at the height of where we would be. What we don't know is how long that plateau is going to last before we see a decrease. And when we look at New York, when we look at Washington, when we look around the world, I think we have some evidence to suggest that it will last a while. It's not going to go up and go down in a day or two. And the reason for that is probably because what we see is that what happened 3 or 4 weeks ago in terms of somebody getting sick only manifests itself 2 weeks later. When somebody got infected, it's only 2 weeks at most, 2 weeks later that they then are sick. And then we are frequently seeing people who are sick, maybe not that sick, but get much sicker about a week after they started. And then when they come into the hospital, they're very sick and they stay for long periods of time, particularly those that need to go into the ICU and go on ventilators. We see them staying on ventilators for a really long period of time.
Like 2-3 weeks.
Well, it depends, but it certainly can be. It's longer, certainly, than we would typically see in our ICUs. Mm-hmm. And what that means is that we will almost certainly have a prolonged plateau before we start to see that decrease.
So I can't just leave it at a while, though. If I
Yeah.
hold your feet to the fire,
Yeah.
what are you thinking? Several weeks?
Yeah, I don't know. So anything I say is going to be, I guess, a guess. But based on what we've seen elsewhere, my guess is that we're 7 to 10 days before seeing this really significantly start to decrease. And remember, even when it starts to decrease, we'll still be at pretty high levels. So I think we're a week or more from a start of a decline, and we're many weeks away from being able to say, it's really not an issue anymore. I think that's a ways out.
Okay, that's clear enough. And do you have a sense of why we got it so bad?
Yeah, well, I'll say, once again, we don't know for sure. I think that there are some factors here that include the fact that, it's a fairly densely populated area as opposed to some of the rural areas that, may see it later, but haven't seen it as much. I think some of it has to do with timing. Some of it may have to do with a number of almost, I don't want to call them random events, but unlucky events like the Biogen conference. And that's not as uncommon as you would think. When they look at what happened in Italy, there's speculation that a single soccer game there resulted in a real explosion in northern Italy. And I think it's not impossible to imagine that one or more seeding events here occurred that meant that we would be earlier on the curve. But we weren't completely unlucky, so to speak, although it feels very unlucky, and certainly, lots of lives affected. I think we benefited from coming after New York, because I think we were able to see what was happening there and take some time that they didn't have to get ourselves organized individually within hospitals, within healthcare systems, but maybe more importantly, as a state. And I think there's been some really good work there statewide to mitigate what could have been much, much worse.
Although my sense was the hospitals were really preparing pretty promptly anyway, right? But yeah, you're saying as a state, we had the fear of God put into us by what we saw in New York, right?
Yeah, the hospitals definitely did not wait. And the hospitals jumped into it and were I would just say, by the way, we have been thinking about and preparing for pandemics for years. So anybody that would suggest who could have imagined that there would be a pandemic? Well, those of us in healthcare could have imagined and did, in fact, think about it. And there's been both preparation and, we've all been through drills and thought about how to prepare for a pandemic. Like everything, though, real life is different than drills and preparation. The hospitals did jump in. The truth, though, is the virus doesn't respect hospital boundaries. It doesn't respect healthcare system boundaries. And to really be effective, we needed to quickly find a way to work together across those boundaries. And that's something, again, that I think has occurred in this state to our benefit. That has allowed us to, again, mitigate some of the worst case scenarios that could have happened here. And it doesn't appear will happen.
And in fact, like all the Boston hospitals are coordinating and helping each other with the patient flow and so on, right? Like it really is a united front, pretty much.
100% is a united front. I suspect that you having reported on healthcare in Boston for a long time, know that has not always been the case. Any sort of divides between us completely disappeared with this pandemic. We almost function as a single uniform healthcare system. I talked about the fact that the healthcare system leaders talk to each other multiple times a day.
Good to know.
And that's something, that's something that I hope continues into the future. But it isn't just the healthcare system leaders. The states jumped in, the city of Boston's jumped in, and not to disparage anybody else, but if you compare in New York State, I'm not sure that the mayor of New York and the governor of New York communicate to each other. I can tell you here, it's a very different scenario.
That's nice. Well, Massachusetts has a nice tradition of, for example, all sides united in terms of getting close to universal health insurance coverage and so on. It is, yeah.
Yeah. So we've seen the legislature here, the attorney general, the mayor in Boston and other mayors, and the governor all working together pretty closely. We're all on a call together every day in the morning to kick it off and sort of see how everybody's doing and distribute things around as needed.
Great. Okay, so let's move to capacity and staffing. I think the question that is often closest to people's hearts is, if I get sick or my loved one gets sick, will there be room for us? It sounds like you're saying, yes, there is, no problem. Are you in fact saying that? And also, one thing that's a little confusing is that if there's plenty of capacity in the hospitals, why are we having these field hospitals that are already treating patients? And do you think we'll need more of these alternative spaces, or are the hospitals enough?
So there's a lot in there. First of all, I would say there is no question that if you are sick, and by the way, if you are sick means if you have COVID or if you have anything else that needs our care, we're there for you. We can take care of you, and we will take care of you. I would not go so far as to say no problem, wide open. We've been extraordinarily busy. And I mentioned that our ICUs are at 115 or 130% capacity, but we've surged, like the surge itself, to make sure that we've got enough beds. And so we do. There are a lot of reasons, though, actually, that we've been able to make room. And I think you bring up a good example. The field hospitals that have been set up, and there have been a number of them set up throughout the state. The DCU in Worcester, there's one set up on the Cape, but there's also one, Boston Hope, right here in Boston at the Boston Convention Center. And it has also been very helpful in terms of making sure that we have beds available for the really, really sick people. So all of the hospitals have used that for is people who are well enough to move out of the hospital, but not well enough to go back home. We're able to move them out there. They get good care there and allow us to free up beds in the hospital. So that's been part of the fact that we do have availability.
And if we hadn't created those field hospitals and you hadn't done your surge planning, what would have happened?
It's hard to say. I think what would have happened is we might have managed it. We would have been even more full and potentially overwhelmed in ways that we're not overwhelmed now. So you never know. My sense through this crisis is we've always found a way to make it work, but it would have been worse.
Okay. Personal protective equipment. What is it like as a hospital system leader to try to get PPE, ventilators, all the equipment you need? I'm sure you saw there was an amazing account in the New England Journal of Medicine by Andrew Artenstein, the chief physician executive at Bay State Health, about this wild chase that he had to go through to get the PPE that he had paid for. So how's that going, and is there enough, and will there be enough?
Well, I guess I'd start by saying that I never imagined that I would be talking daily about supply chain. And
but they don't teach that in med school, right?
That's right. And that we would all be intimately involved in counting the number of masks and gowns and gloves that we have, and scouring the earth. And that is not an exaggeration, really scouring the earth for supplies, because what happened was really the worst case scenario. It came on suddenly. We live in a world that isn't this isn't true just of healthcare, where we have just-in-time supplies really for everything in this country. Many of those supplies come from countries that were hard hit before us.
Yeah,
And
Italy.
like Italy for swabs.
China.
Many of the masks come from China. And all of those things came together and meant that a lot of our typical lines of supply dried up almost immediately. Now, many of us did prepare. And I wouldn't tell you that it's as if we had nothing stockpiled. We did have, but we were very concerned, and I think appropriately concerned, about running out. And there were days early on where we were concerned that if nothing changed, we didn't change the way that we used personal protective equipment, if we didn't get more supply, if we didn't find ways to reuse it by sterilizing, that we would run out in 3 or 4 or 5 days. That did not come to pass. And it didn't come to pass because, like with a lot of things in this crisis, I think we had to get creative. But it was very unfortunate. I think people were uncomfortable, and rightfully uncomfortable, with not having as many masks as they would have wanted, as I would have wanted them to have. People were uncomfortable with the idea that we would reuse. And those are things that we had to do to make sure that we would have enough. We ourselves got inundated with offers from people that we know, people who had contacts in other countries, offering to help get us supplies. Early on, they were well-meaning, but many of those things didn't come to pass. There were supplies that were available in China, but were not getting out. And then there were definitely cases of supplies arriving somewhere in this country, but not getting to us from where they landed.
Why
and
not?
I think, well, we don't know exactly, but I can tell you that is not something that we have experience with in the past. If we see something that's going to be shipped to us, we can follow it, just like if one of your listeners orders something on Amazon and sees where it is, we can track it too. And we saw stuff getting stopped along the way. We now believe that we have more supplies, certainly, than we've had in the past. And we're more comfortable, although not yet where I would like us to be. I worry about the next wave. I worry about the fact that we have enough now, but you never know if it gets cut off again. And so we're continuously scouring the earth to get more.
Wow. So this is so mind-boggling. I just want to dwell on it for a minute. So these would be supplies that you had contracted for and paid for, and yet they would not reach you. And there have been some reports of the federal government stepping in and taking things. Is that what happened, or what happened?
So I am talking about supplies that we contracted for, paid in part for, at least. I think we, in most cases, were reluctant to pay all of it up front, given what's happening. But yes, paid in part for it. And the supplies just didn't reach us in some cases. And in many cases, actually, supplies did reach us, but not in the quantities that we ordered. I don't know exactly why and how those supplies didn't reach us. I certainly read the story that I was pretty horrified to see. We didn't specifically experience that. So I don't know the reason why they didn't arrive. And I think that it probably was a combination of the chaos, the confusion, stuff coming out of another country where their own customs were stopping things, and potentially things going on here too. I think there'll be a lot of books written about this in hindsight.
There will. A lot of investigations. Okay. This is, I think, kind of the central question of the evening. I am going to try very hard not to whine. I think it's not seemly for a public radio reporter to whine, but we all have this sense of like, when will this be over? How do we get out of this? Can we see the way? And I want to combine a couple of questions that we got from listeners. One wrote, normalcy tends to be at the forefront of everyone's desires, but how can that be attempted and protected from resurgences without a vaccine? Would it be convalescent plasma, which is, of course, using antibodies from people who've had the virus to help treat those who get it next? And then another listener writes, I hear from studies and articles that the number of people infected but asymptomatic is well over 50%. Testing temperatures won't work. How will we be safe? I think that's the central question. So,
well, I guess, again, what I would say is the things that concern your listeners concern us in healthcare too. Those are not unique to lay people out in the field. I think that there is not going to be a single solution to this. I almost said silver bullet, but I don't actually like that phrase in the context of healthcare. There's not going to be a single solution to this. It is going to take a multi-pronged approach. It's going to take a combination of continued social distancing for some period of time, almost certainly longer than people are comfortable with. And it may take multiple attempts at social distancing, sort of opening and closing. That's going to be one. It's going to take concerted effort to work on scientifically valid treatments, not what our gut tells us, but using real science to understand what works and what doesn't. And that, unfortunately, takes time and patience. It's going to take work on a vaccine. It's going to take ramped up testing. And it's going to take a hugely enhanced effort around contact tracing. And any one of those things is a massive effort. If you think about combining them all together, that is even bigger, but it's going to take all of those things for us to do it. Now, I actually believe that we have the ability to do these things if we put our mind to it. Mm-hmm. Let's take as an example contact tracing. We've got to ramp that up in a huge way. We've got to ramp that up in ways that other countries that have been more successful at containing this than we have done so. But it will take thousands and thousands of people working at that. Yeah. In the 1930s, the WPA was created, the Work Projects Administration, and they worked on infrastructure. I think we're going to need something similar in this country. It's an economic time that, in fact, may be similar to the 1930s. But instead of a regular infrastructure, we need to work on a public health infrastructure. And if we were to devote ourselves in the way I think that occurred then, we could beat this thing.
My only reservation about contact tracing is that if you have a virus that seems to be mostly or very heavily transmitted while a person is asymptomatic, possibly for days, it just seems like a huge endeavor to try to trace enough contacts for those people.
It is a big endeavor. And it's going to be useless if we don't combine that with enhanced testing. And if we don't combine that with looking for better treatments. And if we don't combine that with making sure that we socially distance. It's all of those things together that will make each component of this manageable. If all that we try to do is work on one of those things, it'll almost certainly be unmanageable.
Yeah, that makes sense. So here's another listener question related. It seems premature to be talking about what comes next since we have so little knowledge of what life will look like. In any case, what does next even mean? And a similar question, in this state, we are in 2 months or 6 months, is it realistic that we can stay home, or does a tough decision need to be made? So I think both these questions are asking you to paint the picture of the next few months in terms, that was a beautiful job of what the solutions look like, yeah. But now what are our lives looking like in the coming months? months?
So I think there would be very few people who would suggest that we're going to continue for 6 months or a year hermetically sealed in our houses the way that we are now. But I would also suggest to you that it would be very, very premature to talk about opening up and just behaving the way that we did behave, say, next week. That would be a huge mistake. And then we would almost certainly overwhelm our healthcare systems. I think it's more likely that what we will see by the numbers, and this is going to be driven by the numbers and by the science, not by gut, is that when the numbers drop below a manageable level, and we see that they are moving towards no significant increases in day-over-day cases, we will start to open things up, and it will probably be done in a phased fashion. Those things that are most important will be opened up first, and then other things. I do think that it's likely that large gatherings won't be permitted for a long period of time. And I think it's also possible that we need to be ready for if there is another spike, which, as we look around the world, we certainly see that happen. We'll need to be ready to clamp down again. Perhaps not for as long as this time we did. And if we do it early enough in the next wave, it won't have to be for as long. But it's certainly possible that we'll see multiple waves of this. I don't think anybody's suggesting we're going to sit the way we're sitting for 6 months without change.
Good to hear. Okay. All right, one clear marker of next is when hospitals like yours begin their elective procedures again. Actually, I just heard on the news, Governor Cuomo has said in places in New York where there are really major layoffs of healthcare workers that they may start easing those procedures. So when might the Beth Israel Lahey Health Hospital start transitioning back to elective procedures? And by the way, listeners, I should point out, elective doesn't mean like cosmetic surgery. It means like colonoscopies and mammograms and hip replacements. So they're not that elective. They just were things that could be postponed. So when might you start transitioning back to those, and what do you think that could look like?
Well, a couple of things there. First of all, Beth Israel Lahey Health as a system will not be doing this on our own. All of the healthcare systems together will work with the state to make sure that the time is right to start opening up those procedures. I think in order to answer the question, you need to go back to asking the question, why did we shut those things down in the first place? And if you think about why we shut down what we call ambulatory, meaning stuff that happened outside the hospital, and elective procedures, meaning stuff that isn't emergency, we shut it down really for 3 reasons. We shut down because we knew we needed to create capacity in the hospitals for the coming surge. So we couldn't fill the hospitals with things that weren't an emergency. That was the first reason. The second reason is we were concerned that we would be using our PPE, our protective equipment, on elective procedures and not have enough for the COVID surge. And the third reason was we believed that we needed to protect the patients themselves that might not have COVID and our caregivers from bringing people in and potentially getting exposed. And those were the 3 main drivers for shutting those things down. I think we need to think about that as we think about opening up again. And as we get more comfortable that we've passed the peak and that we have capacity, the first issue will solve itself. Mm-hmm. As we gain more confidence that we have enough PPE and access to more, the second issue will solve itself. And the issue of social distancing and not exposing people, is one where we're going to have to weigh the harm that we're doing by not doing these procedures against the benefit of exposure. We think we can safely take care of people and minimize the exposure they'll get. We're really worried that we're increasingly seeing people that have emergency care that they should be coming to get, not coming to get it because they're worried that it's dangerous. And I would suggest to you that it's more dangerous not to get some of those. If you have a heart attack, you need to come to the hospital and be seen. And it's much more dangerous not to come to the hospital than to come to the hospital. We have ways of protecting people. We have good protective equipment. We've got separate beds and wards and other things. And we're seeing a disturbing trend of a huge drop in the number, 40, 50, 60% drop in the number of heart attacks that we're seeing. I don't think that that's because people have all of a sudden stopped smoking and their cholesterol levels are normal. I think the heart attacks are occurring, but people are just not coming into the hospital. We've seen the same, we've seen a 70% reduction in people coming in for evaluations of new cancer. I don't think that that is because new cancer is not occurring. I think people are frightened to come. I hear stories, and these are anecdotes, but they're important stories of, I heard of a relatively young woman who had severe abdominal pain and waited 5 days to come in and ultimately came in with a ruptured appendix and developed sepsis. These are things that we can't allow to happen. And we need to get the word out that we are there to take care of everybody that needs that care, and we can provide that care. And people need to know that.
And when you say a 70% reduction in people coming in to check for new cancers, do you mean like women with lumps in their breasts? And I mean, what are you, people with melanoma? Like, what are you talking about?
So when we looked, we've had actually a 75% decline in new cancer evaluations. Specifically, for instance, there's been a 50% decline in evaluations for breast cancer. So this means people are not coming in for things that they're worried about, things that they suspect, and things that they need to get treated. People ultimately get that care, but it's going to be late. And we think people need to come in and get it now.
Important. Okay. But so it sounds like what you're saying is it's going to be quite a while until you're back to elective procedures, probably. And so
I think it's going to be multi-pronged, just like opening up for everything else. We're going to divide the kinds of things that we'll do into different categories. The things that are emergencies, we should be doing now, and we are doing now, but we need to get the message out that people should be coming in now. The things that are urgent, but not emergencies, are things we should be doing either now or very soon. Then there's a whole nother category of things that I'd call semi-urgent. You know, it's okay if you wait a week or two or a month, but not to delay it forever. And then there is, honestly, a category of things in healthcare that is not at all urgent. And if you wait to get, just have a regular checkup with no specific concerns, or other screening procedures, not because you have a concern, but just because it's time. If you waited a month or 2 months, it would probably be okay. So we're going to have to distinguish between those things. We have to ramp up testing quickly to make sure that we can test the caregivers and potentially patients that need procedures. And so it'll be a phased approach.
What are the prospects for ramping up testing quickly within your hospitals?
I think that the prospects are good. I think we're already doing a significant amount of testing. There are broadly for COVID, and I'm speaking very broadly, two different categories of tests. One category of tests tests whether somebody is ill right now. And that's really important for us to know whether when somebody presents with symptoms like COVID, that they really have COVID. And those are tests that we are doing now. And in the state, we're doing a fair number of those, although we've restricted them. We're not doing enough. We're definitely not doing enough. We've restricted those tests to patients that have symptoms and are sick enough to be hospitalized, to healthcare workers with symptoms, and patients in the community who might not be sick enough to be hospitalized, but have other illnesses that put them at risk. We need to find a way to ramp up testing even more so that the general population can get it. We've started to do that. We've done it. We're doing that in targeted areas. We're doing that in neighborhoods and cities that are particularly coming out as hotspots. Places like Chelsea and Revere and in Brockton. And so we're doing that there, and we need even more. This state has had more testing per capita than almost any other state, and yet it's still not enough. So that's one category. The other category of tests, tests for something we call antibodies, or that's serology testing, and that is not to see whether you're sick right now. That's to see whether you were sick with COVID and have since recovered. And we're just starting to come online with those tests. Those tests will be very important for us to determine how much of this disease is out there in the community, how many people have been exposed, how many of our healthcare workers have been exposed. And those tests are starting to come online. There are some tests available, and they've not all been completely validated, and we want to be careful about this. But we think in the coming week or 2 weeks, we'll be able to do more of these with good, reliable tests, and it will ramp up then over time. We also need to understand exactly what these tests mean. We know that we'll be able to find that there are antibodies present. We're not sure what it means. We think it almost certainly will mean that somebody was exposed. Whether or not it means that somebody is immune is a completely different question.
Got it. Okay, I want to get to maybe the heart. We have only 15 minutes left somehow. I think there's a great big, hard looming question, which is kind of what are the lessons, what will be the changes to hospitals as business enterprises because of this, because of all this, in a couple of main ways. One is this the telemedicine revolution for real? Now, like I can tell you as a patient, you will pry my virtual visit out of my cold, dead hands. Like I am not going back to parking and all of that. And then secondly, I think a lot of people are seeing a real indictment of the just-in-time supply chain, the keep your hospital lean, a lot of common practices that aren't playing out so well in this situation. So looking forward for hospitals, what are going to be the big changes that we're going to see because of this?
So I sound like a broken record by starting the answer to every question by saying we don't know.
Okay.
But I think certainly there are some indicators of things that will change. I'd also say that history would suggest that there may be changes that we never thought would happen that will occur as a result of this. But I think that there is no question that there will be changes, and some of them will be massive changes in the way that we think about and deliver care. So let's use as an example telemedicine, although I think that's really only one example. For years, we have wanted to get telemedicine to take off. And there were all sorts of barriers to it. Patients were not ecstatic about the idea of using it. Caregivers didn't love the idea of using it.
You should mention insurance companies.
Insurance companies sometimes wouldn't pay for it. It just a huge number of barriers. In the space of a week, in our primary care network throughout Eastern Massachusetts, and we have thousands of physicians and hundreds of thousands of patients, the face-to-face visits dropped to almost zero, and we are doing thousands of telemedicine visits. Not only that, but we're hearing that patients love it. And just like you describe, don't want to go back. We're also interestingly hearing that physicians like it too. Now, not for everything. And there are many things that require you to be there in person and for there to be a physical exam and other things, but many things that don't. And I think it's highly unlikely that we'll go back to where we were. I think there are other larger questions, though, about how we function as individual hospitals and healthcare systems that really should require us to think again. I trained and practiced in another, and I'm frequently asked, what's the big difference between the healthcare systems, say, in Europe, and there are a lot of different healthcare systems, and the healthcare system in the United States? And my response is the biggest difference is there's no such thing as a healthcare system in this country. There is no cohesive, coherent approach to healthcare, certainly at the federal level, no coordinated thought about how we should be doing things. And there is some at the state level, but not enough. This crisis, I think, has illustrated the problems with the fact that we don't coordinate things as well as we should. But I would suggest a microcosm here in the state has also illustrated some great things about how, when you do work together more closely, you can really solve a huge host of ills that you weren't able to solve before. So I wonder whether those are not changes that we'll see also.
Let's hope so. So you mentioned hotspots. There are higher rates of illness and death among people of color. They demonstrate, this is a listener question, they demonstrate the racial character of inequality in our society. How can we ensure an equitable recovery for all? And what are you doing to support underserved communities and work on that question?
So let's start with the facts. There is no question that this disease strikes people of communities of color disproportionately to a huge degree. If you walk into any one of our ICUs, you are struck by the fact that upwards of 40% of the people that are intubated in our ICUs with COVID are people of color. And that is not the same percentage that we would typically see within our ICUs. You would be struck by the fact that if you were to ask what neighborhoods and towns they come from, they disproportionately come from a small number of neighborhoods, of cities and towns around the state, and are not spread equally across this state. And we know that that's true for a number of reasons. First of all, these are people that don't have the luxury of many of them, for their jobs, to use Zoom and work from home. They need to go out into the workplace and are exposed that way. We know that people of color have what we call comorbid illnesses, things like cardiovascular disease and diabetes and other things at a higher level than others that puts them at risk. We know that what happens with transmission of this disease is it's really important to be able to isolate if you are sick. Well, if you have a big house and you get sick and a family there and you can close off a room and a bathroom and say, I'm not going to be in contact with anybody else, that's great. But if you live in a small apartment or a multi-generational home, you can't do that. And we're seeing the result of that. Shouldn't surprise us, actually. Mm-hmm. So the approach, this is not going to get solved in the current crisis. But too frequently, we note these issues as problems during a crisis. We mention the fact that we can't solve it right now, and then we tend to forget about it afterwards. And that would be a terrible thing if this doesn't result in a change in the way that we think about and allocate resources for healthcare. And, by the way, that affects everybody. If we're able to provide better care in some communities, it means we'll reduce the rate of infectious disease across the entire state. Doesn't matter where you live. And so I think that makes a lot of sense. And I certainly commit to continuing to work at this even after we pass this current crisis.
Well, but I mean, you can't change something like underlying conditions during this healthcare crisis, but can't you in fact allocate resources during this crisis to help work on this, for example, by having more testing in the hotspots?
Absolutely, and that's exactly what we've done. So one of the things that a number of the hospitals and healthcare systems did together was to go out into the communities that are disproportionately affected. Chelsea is a good example. Chelsea is one of the towns that has the highest rates of infection anywhere in the state. And we, together with Mass General, opened up testing sites, care sites, providing protective equipment and educational materials there before we went anywhere else. But we've also done that in community health centers. Bowden Street Community Health Center is another example in the Bowden, Geneva area. And, I think we're moving into those areas to try to provide care there and testing there before we go out into other areas, because that's where it's needed right now.
Good. So I can't believe it. We only have 5 minutes left. I have to ask you one political question, but I would like you to answer it briefly because we haven't gotten to my favorite thing, which is the cool science. So maybe we could end with vaccines and swabs. But first, the political question. How would you grade the leadership of our elected officials? Governor Baker, Mayor Walsh, I gather your opinion is high. And then there's President Trump. What would you say?
Well, let me again start with the good news, which is I think our state stands out. And this is not a political issue because I think on both sides of the political spectrum, Republican and Democrats in this state have just stepped up and worked together. And I can't recall in the last 8 weeks when I've needed something, when I've placed a call or texted, that it's been more than 5 minutes to get a response. And we really are just sort of working together to remove barriers. That's the way that it should be. Unfortunately, what happens is that stands out in stark contrast to the lack of any sort of response that we have seen from the federal level. And it just, I think we really realized early on that we're on our own in this state. And we're going to have to figure this out because help and coordination is not going to come from the federal government at this point in time. And I guess I'll just leave it at that.
Okay, that was frank but politic. Let's leave it there. Okay, we just have a couple more minutes. Tell me super cool science. Tell me about vaccines. Tell me about swabs. I'm sorry we have little time left for it, but just blow my mind.
What is so exciting about what's going on in the face of all of this devastation is there's been an explosion of creativity. And science, typically moves very slowly, and it still needs to be very careful. But we've moved at light speed. We've seen potential vaccine candidates come forward in the space of in a period of time that I never would have imagined we'd start bringing them forward. There's Dr. Dan Baruch out of our labs at Beth Israel Deaconess Medical Center is working with J&J on a very promising candidate. And there are a number of other candidates like it. When we couldn't find swabs and that was inhibiting testing, we didn't whine about it. We didn't sit back and say, well, when's the federal government going to give us swabs? We had an enterprising young faculty member go out and figure out how to print 3D swabs and then test them. And by next week, we think we'll have a large number of swabs available that have been validated. We're working on, what's that?
That are 3D printed?
3D printed. And we're working with large companies to make sure that they'll be available in large amounts, not just for us, but around the country. In terms of treatments, all of the academic medical centers are involved in clinical trials for a host of different treatments. And here's where I want to caution us. There's been all sorts of stories out about what works and what doesn't work. And that's not how science works, actually, and it's potentially very dangerous. To suggest, based on a story, that we heard that somebody got better as a result of a treatment, let's use that for everybody, is problematic at a number of different levels. First of all, we don't really know whether something works based on a story. This is why we have protocols for testing things, but we also worry about harm that medicines can cause. And history is littered with examples of treatments that we thought would work and ended up causing more harm than help. So we're working on all of those things. There are good clinical trials going on, but it is too early to suggest that we know what works and what doesn't work.
I think that's a great emphatic note to wrap up on. Huge thanks to you, Dr. Kevin Tabb, and to the CitySpace team who made this event possible. To everyone out there who came, thank you for coming. Our next virtual town hall will be next Tuesday, same time, same place. WBUR's Deborah Becker and Lynn Joliker will be speaking with our guests about how the pandemic is affecting some of the state's most vulnerable populations, prisoners, and homeless people. And Deb and Lynn have both been breaking stories about the rates of infection among those groups and what's being done about them. You can register at wbur.org/events. Kevin, thank you so much for doing this. Thank you to everyone out there. Take care. Wishing you health, safety, and most of all, sanity. Thank you.